I'm going to take a slightly different take on Amazon because what I'm coupling here. So interestingly enough, in late January, gave a talk at a meeting in Atlanta, which was entitled "What if Amazon, J.P. Morgan, and FedEx, okay, that not Berkshire Hathaway, got together to deliver healthcare?" And then about 3 weeks later, Amazon and the other two announced that they were going to do something together. So this is not about how drugs are going to get purchased or delivered in the future. It's very much if those companies brought the capabilities they have in their core businesses today to healthcare, where is it that we would be? So the title's missing the JP Morgan, but it should be there as well. So, okay. In terms of learning objectives, so number one is consider the potential of technologies from other industries and the application they could have in healthcare. Two is to, and Dr. Patel will really drill into this next, discuss how analytics will change the way in which we deliver care. And there's been lots of great talks on this earlier today. And then ultimately, okay, who's going to win out of all of this? So, little thing, could you imagine if JP Morgan couldn't tell you if there had been fraud until, say, 6 weeks after the fact, right on your credit card? Big impact on their business if that happened. Amazon not giving you product recommendations, or FedEx not tracking its packages in real time, right? All three of those businesses would go under if they couldn't do this. Now, let's think about where we're at in healthcare relative to those realities in those industries. Now, analytics in and of themselves, revolutionizing other industries and sports. So, wins above replacement, the one in the middle there. The Houston Astros went from the absolute last in the league to World Series champions in 3 years, adopting the same sorts of analytics that you're about to see. In advertising, they've been doing this for a while, and it's gotten much, much more powerful as they've been able to bring the full power of cloud technology and various other means to understand us in ways that, yes, most of us probably are not necessarily that happy about, but it's happening. And then in retail, the first one, Net Promoter Score. Everybody's asking, okay, would your family member or someone you trust recommend this service? And that kind of thinking is only just beginning to percolate into healthcare, and it's about to come in a big, big way. So we are at the cusp of a revolution in healthcare. Now, what's driving it? Part of it is the payment models. Part of it is the far greater availability of data that we've got. The biggest one is that the consumer's fed up, and they're expecting something far, far better from us. I think the other, which is starting to be talked about, is around staff in healthcare just not being able to take it anymore, and the talk of burnout, which is leading people to finally care about that as well. So it really is those four things. Okay. Mark Zuckerberg gave $1 billion to San Francisco General Hospital. This is a picture of the physician workstation a year ago. Okay. So what have we built in healthcare? I'd say focus less on the chart and more on the story. If we asked a process engineer to come into healthcare and say, please describe, well, they would say it's really interesting because your production model for care is essentially the same. And in fact, in telemedicine, you've replicated most of it there too. You ask the patient to come to an oracle at Delphi. The high priests and the white coats are more important, so generally you're made to wait 15, 30, 45 minutes. You've had to ask a family member to come with you and take a half a day off work. You get seen for 5 to 10 minutes, and then on a white slip of paper in some form of gibberish, you're given the next couple of steps on your journey if you're lucky. And then you're told, hey, this was such an awesome experience, you get to do it again in a few weeks. Okay. Now, when we get in our cars today and we say, hey, I want to go from A to B, you don't go to AAA to get the triptych that, click, click, click through the paper maps. You type in the address, and based on what's going on that day, Google or Waze says, well, here's the best road, and if there's traffic along the way, I'll reroute you. That technology, there is zero reason why we don't have that in healthcare right now, other than some of what was talked about earlier this morning in terms of the root causes of what's driving the difficulty to move things in healthcare. Okay, so what is it that we truly would need to deliver an experience that would generate a net promoter score more in the 70 or 80s and a total cost of care that is, say, 10% lower? Now, interestingly, I picked those two things because speaking to a large insurer that most of you know a month ago, they articulated that their goal in multiple local markets is to create primary care-driven, local Kaiser-style systems that deliver those two things. Okay, so what you'd want is an experience more like the following, which is when a patient comes in, and there's going to be some notion of a care journey, that this is not, hey, I need a flu shot. All right, that's a different thing. But this is, I'm going to get a hip replacement. I've got to go through a journey with breast cancer. I'm having a baby, and that's going to, be 9 months plus the 3 months afterwards. However you want to frame a journey, but something that's like that. Ideally, what would happen is at presentation, there would be a set of analytics done about you as an individual that would not replace the physician or the nurse or the care navigator, but would give that individual the confidence to prescribe an end-to-end care map. Now, even if that care map were on paper, we would do ourselves a massive benefit in terms of narrowing variation. Because the act of prescribing a care map implies the prescription of a service promise to the customer. Now, in that prescription of a service promise to the customer, it enables the memorialization of what virtually all great clinicians do when they spend a bit of extra time with their patient. There's a you do, we do conversation where it's, hey, we as the care team will do X, Y, Z to help get you better. But you and your family members need to do A, B, C, and but it's okay. Yeah, no worries. And using software to be able to memorialize that kind of an interaction and be able to make the map available to patients. Could be on their mobile, could be through the web. You can design your own supports and care teams and make them available to you. Just putting down the map would do a ton to reduce anxiety and variation. Now, what if in addition to that, you made the map dynamic and live, and as new information came in about the patient, you could change it as you went along? That's going to be the future of care, and it's not just the future, it's actually being implemented in places like Hoag right now. Okay, so it's what Jennifer Mitzner showed you earlier today. And essentially, if you think of the FedEx and the Amazon analogy, so how is it that FedEx is able to do what it does today, which is on our mobile phone? If we ordered something yesterday, but we want to change the address, we can, because they could basically tell us which shelf of which truck or plane it's in right now. So they're able to do three things. They have predictive analytics to decide what's the best way to send whatever it is they're sending us, ground, flight, whatever that might be. The second is they're able to track the assets they're interested in real time. And the third is they're able to cause the labor that's involved in moving the asset from A to B to do so effectively. Now, interestingly, in healthcare, the analytics, the patient engagement, and the care orchestration are typically sold separately. They're typically not linked to each other. There's different systems in different therapeutic areas. And yet, whomever at the end of the day is meant to ensure that things run efficiently and that the patient and the staff are happy are ideally looking for something that would link all of those things. So what needs to happen is these things not all need to speak together. Now, interestingly, while EMR makers would love to think that they'll be able to do this, being set up to be a repository of information is not the same thing as being set up to be an optimizer of workflow in real time. And there's a key difference there. Okay, so To do this, you need massive data sets. And you'll see some examples of this in a second. So it requires the ability to union claims, clinical, and social determinants data. It also requires the same type of power of analytical prowess that you find in banks. So what's happened in the banking industry in the last 20 years is there have been billions of dollars of investments by each of the banks to move away from electronic data warehouses where you have to pristinely clean the data before you do anything with it, to what are known as data lakes, where the data is tagged and then it's just thrown in there, whether it's dirty or not, okay? And then with the compute power that exists today, you're able to create layers of algorithms that automate the cleaning, the joining, and the calculations of the data based on the use case. The reason that's important in healthcare is certain use cases. So if you're going to use machine learning and AI to titrate the way in which you control a ventilator, you're probably going to want to make sure that the data elements going into that are clean going in. If you're doing something, though, that has to do more with billing or revenue cycle, you might tolerate less of a level of precision. The speed at which these platforms can process data. Now, where does this come from? So in financial services, what's essential for them to do in real time? If a new trade comes in and you're an individual or you're a pension fund and you log in and you want to know in that minute what your portfolio is worth, imagine the calculation power that's required to take all of the world's trading volume as it's happening and then render that back to individual accounts. That's what they do in financial services, and the security has to be the same grade as it's required for in healthcare. Okay, so if you bring in that kind of technology and marry it with the amount of data that's available today. So one of the little known things that happened with the ACA is Medicare made its entire data set available. Now, it takes a while to be able to get access to it. There's only 7 organizations in the country that have it nationally. But for 42 million fee-for-service beneficiaries in the country, identified, you get all of Part A, the hospital bills, all of Part B, the out-of-hospital bills, and all of Part D, the drug bills. And there are ways now to union commercial data into that. Now, clinicians will say there's zero value in claims data for the purpose of improvement. Okay, so where does the claims data come from? The EMR. Okay, so it comes from the same place. Now, it is absolutely true that the kind of analytics that have so far been done and presented to clinicians from claims have been virtually useless. The reason is they were too high level, and it's not a ton of fun to get a report with 9-month-old data that's PDF that you can't click through and try to engage in the same way that if you're sitting down. And it was a great example from Martini Clinic, because what I heard there was they're not just receiving the reports, they're sitting down together and discussing it, and then interrogating, and then asking a deeper question. So ideally, you'd want a platform that when you say, hey, I have a question, you can then drill down in real time, right? That's what they have in banking. It's called the Bloomberg terminal. So what if we had a Bloomberg terminal for healthcare? Okay, so what does it look like in practice? And in this new world order, let's use an example from spine, and in this case, it's data from St. Louis. So we didn't stick with LA, so there wouldn't be any issues here in this case. So what do you see here? The example is spinal fusion. The metric that you're looking at across the top is a spine episode of care. So it's a total cost number. And it's similar to some of the data that you saw earlier this morning. So these are all individual surgeons. The information people typically get today from other folks out there is the colored dots. So what's your actual performance? And rightly so, physicians will say, awesome, it's great that you're showing me this, but my patients are different, right? Yeah, my patients are different. And I will eat crow because I worked at McKinsey for 15 years. And when I kept hearing this, when we were doing hospital operations improvement work, I said, guys, come on, 20% maybe. Okay, on the variation? Not at all. Same sort of stuff that you see in Germany. Here, the variation in case mix is from 30,000 to almost 47,000. Okay, and we see this every episode or therapeutic area we look at. Now, what are some of the reasons for this? So, younger surgeons know very well who gets some of the harder cases or the train wrecks, right? Because it's a rite of passage that that's what you take care of, and then when you're more experienced, maybe you do a little bit less of that, right? There are other things like this that some people are the ones handling the traumas, etc. There are very, very good reasons why case mix varies in terms of, you know, who's getting what. Okay, so what you have to do is be able to say, great, this is your performance. This is what would have been expected to be your performance if an average surgeon of exactly your category had taken care of your patients. All right. So immediately what happens when you show somebody something like this, oh, and quick thing here. This notion of a confidence interval, if you want to engage physicians in their own language, 5 to 95%. That's how all of research is done, okay? So it becomes hard to say, hey, I'm an outlier outside of 5 to 95%. Yeah, maybe there's something there, right? Okay, so next question is, well, how did you generate that blue diamond? And can you show me exactly my patients? Okay, no problem. So here's exactly your patients. So what you see here is an example where if you had this is a Medicare population, a normal 65-year-old for, in this case, the metric that's being looked at, different, this is a total joint episode. A normal patient would have cost $20,834. Now, these are in completely apples to apples dollars with all of the Medicare factors taken out. It so happened that there were a bunch of hip fractures in this analysis. There were a bunch of patients who were older than 65. There were a bunch of women. Okay, so interesting thing we found out as we've gone through this. Why are women more expensive on an episodic basis than men for things like total joint? Absolutely. Their partners won't take care of them at home. And so they stay and sniff longer. Okay? So what you can do is say, hey, these were all of the characteristics of your patients that came up. 27 of them had hypertension, 15 of them had diabetes, etc. This is why, if they had all been normal, it would be 20,000. Yours should be costing 31,000. Okay? Now, the other thing, risk stratification methodologies out there today tend to do this. Most people won't talk about it too much, but the weight that they ascribe, for example, to hypertension, because the compute power isn't there to individualize it, it's the same weight for the impact of hypertension on a stroke versus the impact of hypertension on total joint for, say, a readmission or total cost, etc. Well, any clinician knows that the impact of hypertension on stroke is different than it is on total joints. So one of the reasons you also have to bring in the same kind of power that they've got in banking is you should be able to, for every metric you look at, come up with a different weight for the impact of hypertension on the metric you're looking at. Okay? If you start doing those things, you can get as precise as the baseball teams are about, hey, I only have $3 million to spend and I need a new left fielder. Who's the best one for me to get? Okay. Now imagine these kinds of analytics in healthcare. Obviously very helpful in the context of a bundle where you're trying to learn how to improve. But you can imagine what the payers might start doing if they start doing those kinds of analytics themselves, right? So in the new world, anybody who stays on the right-hand side of the bell curve, doesn't really matter what the payment model is going to be. You're likely to end up in the right place because push comes to shove, the volume is likely to come your way. And anyone who's on the left-hand side of the distribution is likely to start struggling to some degree. And that's you know, what absolutely you say, hey, this is real data from the Bronx. This patient in, this physician has 1,349 over 65 in this case, his panel. And again, fully case mix adjusted, is ordering imaging at 4.4 times the rate. And if you clicked on that, it would say MRIs, various kinds of imaging. Now, it turns out that one has a stake in an imaging center. Okay. Now, what you can also do is to say, okay, what do the referrals look like? And if you're able to look at the efficiency of specialists on episodes, length of stay, whatever the metric, you're also able to comment on, you know what, your referrals to cardiovascular are to more expensive folks, and it's actually your CHF ones. Your arrhythmias are fine. Your pulmonary referrals, there's no issue with them. You can start tracking all of that stuff. And then ultimately you can look in an episodic context at which of your SNFs, for example, you want to work with. So that gives you an idea on the analytics. On the patient engagement front, if you start using the same kind of analytics to risk stratify them up front, to match them to maps, all of a sudden you can make the patient engagement tools that exist today, but quite frankly are a bit stranded. And they're stranded because they tend to be flat pathways that don't change. The other thing most folks have missed is that the nurse workflow today to manage patients is hell. You have to open Epic, open a spreadsheet, and have a stack of Post-it notes, and you're entering the same information 2 or 3 times. So what we need is systems that you ideally pre-populate the stuff you can already from the EMR, and you only have to enter what it is that's required to then do a great job only tracking the patients that need to be tracked, right? Exception-based care navigation. And ultimately, you end up being able to produce visualizations like this where, okay, these are the patients that you really need to take care of today, and the others you don't need to worry about because they've either told you they're okay, or because you can geolocate their phone, you know that they're at home and not unexpectedly overstaying in a SNF or in some emergency room. And creating that kind of real-time care traffic control and care guidance. So some of it may sound a little bit like science fiction, but the technology exists, it's real. And certainly in things like spine, total joints, stroke rehab, even soon to be in oncology, it's absolutely possible to deliver an amazing patient experience and to do so in a way where the costs come down and those big contracts that come out for RFPs ultimately are yours as opposed to somebody else's. Okay.